not to run things too late, but I guess we can just get started. But first, yeah, I'd like to thank Dr. Grant, Dr. Janopaul-Naylor, and Dr. Moningi for coming and participating in today's session. But yeah, I'm happy to announce that we're having our first ROVER case-based teaching session for the year of 2025. And so the first topic of discussion for this year is the GU malignancies. And so happy to have Dr. Grant from UT Southwestern, Dr. Janopaul-Naylor from MSK, and Dr. Moningi from Brigham and Women's, or MGH. So we'll be talking about a case on bladder cancer today, one case on salvage prostate, and then the last case will be a renal cell carcinoma. So when our panelists are presenting their case, feel free to put any questions in the chat, and then after each case, we will give a few minutes for Q&A. All right. So moving forward, I'm Yen-Ruh Wuu. I'm one of the PGY4 residents at Northwell Health, and I'll be moderating today's session. So to start, I'll let Dr. Moningi take over.
Thanks, Yen. Thanks, Jenna and Yen and the rest of the ROVER team for inviting me today. I'm going to be talking a little bit about bladder cancer this morning, or I guess this afternoon here, and a case-based discussion about it and just touch on a few trials. I have no disclosures. Yen, how do I
can
Oh, thank you. Yep. That's great. So we'll start out with the case. We'll touch on staging, imaging, some treatment paradigms for bladder cancer, specifically the muscle invasive bladder cancer patients, treatment planning, some of the details with regards to that, and then symptom management. Yen, could I get the next slide? Thank you. So our initial presentation for our case, so there was a 65-year-old woman presenting to your clinic. She shows up with abdominal discomfort, some fullness. She's had a lot of weight loss over the last couple of months, and hematuria. When you ask about past medical history, she has COPD. She has a history of GERD and rheumatoid arthritis. She's actually a secretary in a different department in the same hospital. She's a current smoker, and she has a 40-pack year smoking history. When you talk about review of systems with her, she does have nocturia. She wakes up twice at night to pee. She doesn't have any burning with urination, and she doesn't have any incontinence and doesn't use any pads. So our first poll question is, what is your next step for workup when a patient presents with hematuria? Is it a urine analysis? Is it imaging with a CT scan of the chest, abdomen, pelvis? Would you want to get an MRI pelvis, or would you want to get labs, which would include potentially a complete blood count and a complete metabolic panel? I should have put that on my slide. Okay, so our results are in. So 83% think a urine analysis is the right way to go, and I agree. So you'd first want to get a urine analysis. You want to make sure the patient doesn't have an infection. There isn't anything surprising coming up in the urine analysis before you start doing some imaging. So her UA came back negative for any kind of infection. She then gets a pelvic exam, which was not notable for anything concerning. And that's when you decide to get a CT scan. So you get a CT abdomen pelvis, which shows this intraluminal bladder mass on the right. And that's what the yellow arrow is pointing to. Thanks, Yen. So further workup, you decide to send her to urology, and your urology colleagues do a cystoscopy. And they find that in the right bladder wall, there's about a 2 to 3 centimeter lesion that looks high grade from a gross perspective, and it's posterior to the right ureteral orifice. The patient then gets a TURBT. So TURBT is short for transurethral resection of the bladder tumor. And the TURBT shows a high-grade papillary urothelial carcinoma with muscularis propria invasion. And in the specimen, it's stated that they did have muscle of the bladder within the specimen. Her labs looked fine. Her renal function is fine. She doesn't have any kidney problems. Her CT, abdomen, pelvis, and chest did not show any signs of metastatic disease, and there was no lymphadenopathy seen on imaging. You also get an MRI, and that confirms this 3-centimeter lesion in the intraluminal, 3-centimeter intraluminal lesion in the bladder wall on the right side, and it also confirms that there was no lymphadenopathy. Next slide. That's the MRI. So on the T2 weighted, you can see that lesion on the right side. You can't appreciate it on the DWI, but normally when you get a DWI, the lesion should appear bright in nature. And so that's something to look out for when you get imaging, and especially at MRI. So staging, so you have this patient who's a 65-year-old female. She has high-grade papillary urothelial carcinoma with muscularis propria invasion, no lymphadenopathy, and no signs of distant metastasis. So that leads us to our next poll question. What would this patient stage be? Would she be a T1, N0, M0, T2, N0, M0, T3, N0, M0, or a T2, N1, M0? Okay, so everyone got it right. It's a T2. And so we're going to go into a little bit of staging. But before that, I see Jenna's question, so we'll just pause a little bit and have a discussion maybe with Dr. Janopaul and Dr. Garant about your thoughts on MRIs. We occasionally have been doing MRIs, but not on each patient. It just happens to be that this patient ended up getting an MRI. And that's because we'll go into it in a little bit, but at least at Brigham and MGH, we tend to do the hypofractionated approach of 55 gray and 20 for the entire bladder. So we're not necessarily boosting a specific area, so it doesn't help per se with the planning. I'm curious what you guys do.
I would agree with that. It's not very common here either.
We should get it a little bit more often. I think we have pretty aggressive surgeons, and so they really want to know if there's like a maximal TURBT, and so they'll often get it and make sure there's no residual thing to scoop out. I guess with your comment, I'm curious how often you ask for fiducials at the time of TURBT, if you're just going to treat the whole bladder.
We actually don't ask for fiducials because we treat the whole bladder. Sometimes they do place it, and I think it can be a little bit helpful, but our CTV includes the whole bladder, so it doesn't necessarily change our planning. What about you all?
I would agree for conventional management, we will not place any fiducials. We're currently accruing to a pulsed radiotherapy with EV pre-op trial right now, and adaptive radiation is allowed on this trial, so we do have high resolution imaging as an option online, but that's kind of a parenthesis. Yeah,
that's good to know. Awesome. Thank you, guys. And as you can see, every institution is a bit different in terms of how we treat bladder cancer, and we're going to some of those details towards the end of this end of these slides. And so this patient was a stage T2 N0 M0. So we're going to go to the next slide, and if that's okay. Yep. So I want to touch a little bit on staging for bladder cancer, and then we can talk more about treatment planning. And so bladder cancer T stage is dictated by the depth of invasion of the tumor into the wall of the bladder. So these tumors really start and they form in the inner lining of the epithelium and then start growing outside from there. And so when we think about bladder cancer, we think about, the lower stages are TIS or carcinoma in situ and T1 tumors that are non-muscle invasive. When you hit T2, you have muscle invasive disease. T3 is when the cancer goes through the wall of the bladder, and T4 is when it grows into the adjacent organs. Clinically, when we think about bladder cancer, a lot of times you see sort of the big differentiation of non-muscle invasive disease and then muscle invasive disease. And then of course you'll have locally advanced disease and metastatic disease. But when it comes to sort of treatment paradigms locally, that's what we're going to focus on, are non-muscle invasive versus muscle invasive. Next slide. So this is just just for reference of nodal metastasis. So when we think about N1, N2, and N3 disease and staging these patients usually that have N1 or N2 disease have lymph nodes that are more involved in the true pelvis, so closer to the bladder. So you're thinking about the obturator lymph nodes, external iliacs, or presacral lymph nodes. When you hit N3, you are seeing lymph nodes sort of higher up at that common iliac lymph node echelon. So the further it's going away from the bladder, the higher your nodal staging is going to be. Next slide. Thanks. So this is just total staging, so T, N, and M staging. This is something that's super helpful for senior residents out there and junior faculty who are going to be studying for boards. It used to be that N1 actually was under stage 4, and now someone that has T2N1 disease actually has stage 3, their kind of final stage of bladder cancer. And that's something that might come up in boards, and also something just to be aware about, because these patients are patients that could potentially be cured. And so that's why they've sort of kind of bumped down now to stage 3. So it's just something to keep in mind. One thing to keep in mind about bladder cancer in general, the majority of patients who present with bladder cancer actually have non-muscle invasive disease. About 3/4 of patients have non-muscle invasive disease. So you're thinking about the TIS and the T1 patients. About 1/4 of patients actually present with muscle invasive disease, so T2 or higher. And long-term cure rates can range from 50 to 80% and depends on a lot of factors that we'll go into in a little bit. Next slide. Thanks. So treatment options. So starting out with your non-muscle invasive patients, so your TIS and T1 patients. So for patients who have low-grade disease, they usually undergo a TURBT, which is that transurethral resection of the bladder tumor, and then that's followed by observation. Observation usually involves a cystoscopy done by the urologist, usually every 3 to 6 months. Now, when someone bumps up in grade group, meaning when they have a higher grade disease, but still non-muscle invasive, patients still undergo a TURBT, but that's followed by some form of intravesicular therapy, whether that's BCG or mitomycin C, and that's also delivered by the urologist. And these patients also will have continued surveillance and observation after this with cystoscopies as well. Now, bumping sort of more into, and actually before I talk about muscle invasive, an interesting RTOG trial came out with results most recently, 0964, is it 42 or 64? 0946. I keep getting those numbers confused. And they actually looked at patients who had recurrent disease in the non-muscle invasive state, situation. And what they found was that there was actually a role for chemo-RT in patients that have recurrent disease in the non-muscle invasive space. So you'll hear about chemo-RT more in these patients, as the years go on, especially for recurrent patients. So it's something to keep in mind when you're seeing patients in clinic with your GU colleagues. So now bumping up to muscle invasive disease. So for muscle invasive disease, the two paradigms, one is surgery, and then one is sort of TMT or trimodality treatment that we'll talk about in a little bit. And so these are the two curative options for these patients. And then of course you have T4B disease, which is more systemic treatment. You're thinking about chemotherapy or immunotherapy for these patients. So this patient actually decided to proceed with trimodality treatment, and we'll talk about the details of that now. Next slide. Thank you. So what is trimodality treatment? So from a bird's eye view, trimodality treatment includes a maximal resection, so maximal TURBT, followed by some form of chemoradiation, followed by surveillance. There are two paradigms here. I want to start out with the bottom paradigm. So the one on the bottom row is really what we used to do in a lot of the older RTOG/NRG trials, where if you ever hear the word split course radiation, that's what they mean by this. And so it was more of an induction followed by consolidation approach. So these patients would undergo maximal resection, and then they would start chemo-RT. They would get about 3/4 of their chemo-RT dose, so their radiation dose with concurrent chemo, and then they would get a cystoscopy for assessment. If you had a good response, meaning a complete response, there was no tumor seen by the urologist, then they would get the rest of their radiation treatment with concurrent chemotherapy and then be surveyed. Now, if you had an incomplete response and there was still some residual tumor seen on the cystoscopy, then you would directly go to surgery and you would get a resection. Over the years, we've transitioned to sort of the upper approach, the top approach. And so most recently, there was a trial called the BC 2001 trial looking at the role of chemo with radiation. But that sort of helped us with some of the hypofractionation approaches and also showed us kind of a non-split course approach for bladder cancer. So the topmost row is what you'll most commonly see in clinic. And so patients undergo a resection, then they come to you, you plan them and deliver chemoradiation that can be in conventional fractionation or hypofractionation. And followed by this, they undergo active surveillance. And that's going to be with cystoscopies and also CT chest, abdomen, pelvis, about every 3 to 4 months. So that's sort of the paradigm for what TMT is in comparison to radical cystectomies. Next slide. So I just want to have one slide here on how we compare surgery to TMT, something that you're going to hear a lot about and patients are going to ask you a lot about, like, why should I get this? Is this the same? So sadly, we actually don't have randomized data, like true randomized data on this. And I think it's because it's really hard to accrue patients on these kind of trials where you have these two arms. And so because of that, this is the closest and best data that we have so far comparing cystectomy to TMT. And what you've seen, what it is it was a retrospective analysis of patients who had muscle invasive disease at USC, where they do a lot of surgeries, MGH, so in Boston, where we do a lot of TMT, and then Toronto, where they do a bit of both. And they had about 770 patients, and they looked at patients who had surgery versus TMT. And they looked at metastasis-free survival, and they used 2 different techniques of propensity score matching to assess for metastatic-free survival and a bunch of other survival endpoints. And you can see in the curves up top that they're pretty much overlapping. And cystectomy and TMT were pretty much the same in terms of long-term metastasis-free survival. And on the curves on the bottom, they're a little bit blurry, but actually TMT did actually show some slight improvement potentially in disease-free survival compared to cystectomies. Of course, this is a retrospective analysis, so we can't really take that, we don't know if that's necessarily true, but we are using this data to talk to patients and educate them about the fact that TMT is pretty similar to cystectomies. But again, we don't have randomized data, so something to keep in mind when patients ask you about this. So factors that might impact treatment choice. So this was given to me by my colleague, Dr. Mao, who is fabulous and he's a bladder expert. And I really like this figure because it gives you an idea of what patients might be good candidates for surgery versus TMT. So when you think about someone who has really bad bladder function or inflammatory bowel disease or a lot of prior radiation from a different kind of cancer, they may not be the best radiation candidates. And those are patients who might be better off getting surgery. When patients are older, they have a poor performance status and higher surgical risk and can't undergo anesthesia and this really large surgery, those patients might be better TMT patients. And of course, patients who don't want to get their bladder removed and would rather have TMT, those are obviously patients you'd want to consider for TMT as well. There are, of course, patients in the middle where it's really tough to choose. So you have patients with poor performance status, what should they do? Well, they might likely get TMT versus surgery just because of the morbidity of surgery. And if they have a poor performance status at baseline, that might be better for them. If they have hydronephrosis, multifocal tumors, those patients might be better with the radical cystectomy. One thing to keep in mind, chemotherapy in addition to radiation improves disease-free survival and overall survival for these patients. And so if someone doesn't have really good renal function and they need a platinum-based agent, they can't probably get one with radiation. So the efficacy is not as good as getting it together. So those are things to keep in mind when you see a patient and you're kind of weighing the positives and negatives and what might be better for them. Next slide. So now we're going to transition and talk a little bit about planning for radiation treatment for a patient with bladder cancer. So when I sim a patient, I usually sim them supine, they have an empty rectum, and we do empty bladder at our institution. So we'll talk a little bit more about planning, but I usually treat these patients with their whole bladder to a hypofractionated approach. So having an empty bladder is helpful when we do the radiation planning, when we're not boosting a specific area. They usually have PO contrast. That's a great way for us to visualize the small bowel. So if they're able to, we do PO contrast for them, and we scan from diaphragm through pelvis. Now, the treatment options in terms of dose and fractionation, you have your conventional fractionation approaches where you can go to 32 or 36 fractions. You can include the lymph nodes or not include the lymph nodes. And then you have a hypofractionated approach, which is 55 gray and 20 fractions just to the entire bladder. And that does not include the lymph nodes. Next slide. So what do I contour? I first think about organs at risk. So in that area, we worry about the rectum, the sigmoid, the femoral heads, and the small bowel. Now, the small bowel is probably, sort of the weakest link and something that really limits us when we think about treatment planning in this area of the body. Targets, if you're treating the lymph nodes, then your pelvic lymph node chains that you think about, that where is the first echelon where this cancer is going to go to. So it's basically where N1 and N2 disease goes to that we talked about in the earlier slide. The whole bladder, and then if you're boosting the bladder, then, like we was mentioning before, if there are fiducials, you would actually contour a tumor bed or the area where the tumor was removed. In this case, we decided to treat the whole bladder. So the entire bladder was a CTV, and I did a 1 to 1.5 centimeter expansion for a PTV. And in terms of technique, we do IMRT, but one thing to keep in mind is a lot of the older studies that you will read about in terms of bladder cancer actually use 3D and not IMRT techniques, so something to think about. But right now, I think most of us use IMRT or even adaptive on the MR-Linac, like Dr. Garant was saying, daily KVs to make sure patients are aligned. And we also do CBCT sometimes. I like to do CBCTs the first day and probably weekly. Sometimes the bladder can change as patients get more and more urinary symptoms. It is harder for them to empty fully. And there are times where you might have to resim a patient or replan a patient if the bladder basically is not able to empty fully as much as it was at the time of mapping. So something to think about when you're treating these patients. Next slide. So this is just a plan of a patient with bladder cancer. And the one thing I will mention is the yellow is full dose and the green is 52 gray. And as you can see, the small bowel is looping right above the bladder. And so we're going to talk a little bit about dose constraints, but that's really one of the main limiting structures when you're planning dose to the bladder. Next slide. Thank you. So things to consider. So this chart over here is actually, these were the original dosimetric parameters that were used in the older RTOG trials. And I just wanted to bring this up to show you how strict they were on small bowel constraints. And so they really didn't allow a lot of volume to go to 55 gray or above in the small bowel. Currently, with our techniques and I think in general, using IMRT, we tend to allow more volume to go to 55 gray. We tend to, at least at Brigham at Brigham, we go from 5 to 10 cc's. We allow up to 10 cc's, getting 55 gray to the small bowel, and that helps a little bit in terms of planning. One thing to also consider is the location of the tumor, whether it's at the dome of the bladder or whether it's lower down, because that can also make you understand the importance of underdosing on the top of the bladder or not. You also want to consider when the patient has had a prior TURBT and timing. So you want to make sure that that prior TURBT was recent and not a while back. So we usually give it a maximum of 4 to 6 weeks and no longer than that. And if it's been after that, they'd want to undergo a repeat TURBT before getting chemo-RT. And then again, like we mentioned before, concurrent chemo candidacy is super important as well. Next slide. So this is just a list of side effects. I think broad strokes, patients are going to feel tired. They're going to have increased urinary symptoms, frequency, dysuria, maybe incontinence. If they had incontinence in the past, they might have worsening incontinence. They might have diarrhea. Another thing to keep in mind is a lot of these patients are on concurrent chemo. So you're going to notice side effects that are also related to chemotherapy. So if someone's on 5-FU, they might have mouth sores. If someone's on cisplatin, they might have nausea, vomiting, or even diarrhea from cisplatin. And if they're on GEM, they might have issues with their blood count. So something to always think about when you're counseling these patients on weekly C days or OTV days. The other thing to keep in mind is pre-radiation bladder function is super important and is a really big indicator on how these patients do during radiation treatment and after. So when you have someone who comes in with really great bladder function, they're more likely going to do okay during treatment, and they'll probably bounce back a bit better than patients who really had poor bladder function initially. Next slide. So last slide, so toxicity management. Patients who are having any dysuria, you can try ibuprofen if they don't have any kidney issues or they're not on blood thinners. You can also try azo or pyridium, which is very helpful. Spasms, oxybutynin is very helpful. Just keep in mind that that has anticholinergic effects like drowsiness and dry mouth. Obstructive symptoms, Flomax is great. All of us in GU love Flomax. And then managing bowel symptoms, Imodium, Lomotil, great for diarrhea. We usually start out with Imodium over the counter and then bump up to Lomotil if needed. And that's it. So I want to thank everyone here. Feel free to put questions in the chat, or I think that's how we're going to do it. And then feel free to reach out to me too afterwards if any questions come up. Thanks.
That was very great. Thank you for that. It was a great summary of T2 muscle invasive bladder cancer. First question in chat: how frequently are you getting MRIs under bladder cancer patients?
Yeah, so we were just talking about it initially when I just started, but not as much. I had added it in there because this patient happened to get an MRI and it was nice to see one, but we usually treat the whole bladder, so an MRI in terms of treatment planning is not as useful. And so at least at Brigham, not as often.
And then next question real quick. How do you decide between conventionally fractionated versus the hypofractionated?
Yeah, it's a great question. There's been some retrospective data looking at elective nodal treatment for bladder cancer and showing that there hasn't been a lot of benefit with elective nodal treatment. And so a lot of times in the past, people kind of gravitated towards conventional fractionation because they had the ability to give kind of a lower dose to the elective nodes, and then you treat your bladder and you boost this bed. But given that there may not be that much of a benefit, a lot of us have transitioned to the hypofractionated approach. So if I have a node negative patient, most likely I'm probably going to do 55 and 20 for the whole bladder. Now, if I have a node positive patient, then I think that I would consider elective nodal and boosting that node and potentially treating the bladder to a more conventional fractionation approach. But most of the time, I tend to favor the hypofractionated approach.
All right, great. So moving along, I guess next we'll have Dr. Janopaul-Naylor discuss the case on prostate cancer.
Good. Yeah. Great talk. Thank you all for having me. We're going to talk about recurrent prostate cancer. So unlike the bread and butter bladder stuff where there's a lot of defined care paths, this is the Wild West. And I would love to hear what other people are doing because there is not really a standard of care. So next slide. I think I try to just capture a sense of this is, I think, a growing problem, particularly in the PSMA era, is that I think what would happen historically is a patient would have a PSA recurrence, biochemical failure after radiation, and we would just say, go to MED-ONC. And, we didn't really have a curative option. They had already gotten 80 gray in, 8-9 weeks of treatment. And we said, we can't do precise treatment, so we're not curing them. And now we have these PSMA PETs that are showing us really it's just in the prostate for some of these guys, that it's a true local failure. And so we get excited that maybe we can offer something curative. And maybe that is another round of radiation. Maybe that's HIFU or cryo. Maybe that's surgery. And I know that's, an anathema. That's something we always say at our consensus. If you get radiation, you can never get surgery. I think if you look at the spectrum of options, there's not a perfect option. And I think, if nothing else, I tell you, at least think about it. So this is just getting a concept that, there's about a 1%, maybe up to a 5% chance of a local failure at some point in the future. As with all things prostate cancer, 5 years is not enough. So PACE B saying that there's like a less than 1% risk of local failure at 5 years is great. But these guys are going to live for 10, 20 more years. All the data points that those failure curves keep going up later and later. So, I see a couple of these a year. I don't know what other people are seeing, but, yeah, I think you're going to keep seeing them. So let me do the next slide. So here's a case. Yeah, it's not super common, but it does happen enough that we're going to need to work on it. So this is a case. The first poll question is, what do you want to do for this person? But it's a guy with kind of classic favorable intermediate risk. You have Gleason 3+4, a moderate PSA. He was treated 8 years ago, prostate only radiation. Had a nadir, about a year and change after his radiation. It was steady. And then it started just creeping up, and then it hit, that beautiful criteria defined by a bunch of experts at a conference that 2 is enough to call a failure. And so the question is, what do you want to do? You want to get some labs? You want to get some scans? What kind of scans? You want to put a needle in them? What do you all want to do? Unlike prior questions, there isn't a perfect answer for this. All right. Everyone wants a pet. Love it. Okay. Yeah, that's probably would be my first. Yeah, you get a PET scan. I think that's probably your starting point, and then based on that, you might get some other things. So if the PET's not determinate for like if it's got like hazy prostate uptake and nothing else, maybe then you're getting an MRI. I almost never get a CT chest abdomen pelvis or a bone scan, but my pathway would look like PET. If it's not metastatic, we don't have any nodal spread. If there's like a defined lesion, maybe I don't need an MRI, but I usually like to get an MRI anyway, because I want them to be concordant. And then, I'll probably want to get a biopsy just to confirm anyway. And then the labs are really just if you want to do hormone therapy. So next slide. So this is what we got. I'm showing you a somewhat clear-cut case. Not all of them are like this. So, pretty focal uptake, you've got a dominant dark lesion on T2. We get a biopsy, targeted biopsy, Gleason 4+3, the template cores are negative. They didn't do a full 12 core, they did kind of a 6-core sampling. So next slide. So what do you want to do? You've got, biopsy proven, PET and MR recurrence. This guy's 75 years old. He's relatively healthy, but he's not, running marathons. So what do you want to do? His PSA is 2.4, asymptomatic, no hematuria, nothing like that. He has, good urinary function. He didn't have any big side effects from his radiation. Never had hematuria or genitourinary. All right, what do you all say? All right, radiation with hormone, and maybe because I prompted y'all, prostatectomy. Great. Okay. Next slide. So I think this is probably the best paper out there right now is this systematic review, which I think just kind of highlights, I kind of copied and slightly reformatted their table. There's no perfect answer, right? 5-year relapse-free survival is 50 to 60%, kind of regardless of what you do. These are all biased in different ways. So this is biased data. You can look at SBRT and be like, man, that's some low toxicity, but there's definite patient selection in this, right? This is not an all comers who are getting this. Just, for reference, our surgeons usually cite a like 50% chance of permanent urinary incontinence after a salvage prostatectomy. And not just your like 1 pad a day, like full on leaking. So, it's an option. I don't think it's a great option, but, not everyone's a great radiation candidate. Cryo HIFU, I'm not a huge fan of for the upfront setting, but, sometimes, particularly if it's an early recurrence after radiation, you do have to question, is more radiation going to work? So this is, go back one slide. Yeah. So this is kind of how I think about things is the first question is, what are your competing risks, right? So if you have a local recurrence, what is your risk of a distant or a regional failure, right? What is your actual chance of cure with a salvage therapy? And then the other question in tandem with that is, what is their life expectancy? How long do you need this control for? Versus, could you think about some alternative treatment, right? If you do intermittent hormone therapy for an 85-year-old, they might be good. They might never met out in their lifetime. If their biopsy shows it's Gleason 10 recurrence, sure, the PET now is negative, but do they have seeds elsewhere? Are you going to give them potentially a 6% chance of a grade 3 toxicity, and they're going to need hormone therapy anyway a year from now? So that's the competing risk question. The prior treatment, when was the prior RT? Is this a failure 1 year ago? Did they get full dose radiation? Did they get LDR? And this is like a recurrence in where like the seeds migrated and it's actually a low spot. Is this kind of like a distal SV that maybe there was some dose painting? Or is this right exactly where, there was a DIL boost because, you were using modern treatment techniques, and this actually already saw a hefty dose, you know, is that a patient that maybe you want to try cryo first or HIFU or these focused ablative treatments? And then, you know, what will the patient tolerate, right? So did this patient get cystitis after radiation? Did they get proctitis? Do they have horrible urinary retention at baseline since the radiation? Are you going to make that worse? Even if you try and do, you know, focal ablative treatment. So next slide. So this is how I think about like the radiation treatment. I guess let me pause. I'm curious what the other panelists think about what they weigh for treatment selection for salvage radiation. What makes a good candidate or a bad candidate?
I usually have a pretty lengthy conversation with patients. I would say SBRT and HDR are our top two modalities in this setting. If it's very well localized, you know, leave it an open conversation with patients about partial gland treatment. But if it's multifocal, we do request both random and targeted biopsies. If it's multifocal, we'll try to do a moderate dosage to the whole gland and do a boost type of format to whatever's evident. But these are our challenging scenarios. Yeah.
I agree. We do something similar, and SBRT on the MR Linac now more and more for these patients where we can actually, you know, where it's better visualized, and then definitely the other option is HDR. I haven't seen a lot of LDR. I've seen a few cases being done, but really more HDR in the salvage setting for sure. And then hormones, I think it depends on the situation, I think. And, you know, a lot of times I think we push for this too. And you have these older patients who come in with recurrences who are not the best hormone candidates, who don't want to be on hormones again. And there's a whole discussion. And so we end up doing this to maybe save them some time before they really have to, you know, be on hormones again. So.
Yeah, quick comment on this spacer. I've had about a 50-50 success with patients with prior, you know, full dose IMRT. MR tends to underestimate the rectoprostatic fibrosis from prior radiation. So you go in hoping for the best, but sometimes it's like Velcro. There's just no ability to create a space there.
Absolutely agree. I feel like I'm a little agnostic in the spacer Barrigel, but these are like, if I'm going to do it, I almost always try and get Barrigel for these. And I agree. It's not. I tell them I'll try, and if we can get it, we get it. But often you can't. Yeah, I agree. I think I have never seen LDR. I personally seen a case or done LDR. Yeah, we do HDR or SBRT. Where I did residency, we did a lot more whole gland. Where I practice now, we almost exclusively do partial gland. But you know, if we were doing whole gland, we would do dose painting, whether that was HDR or SBRT. So kind of like a reduced dose to the whole gland, and then kind of boost it with DIL. Yeah, volumes wise, I think, you know, ideal is if you can have concordant MRI, PSMA PET biopsy to guide it. You know, you're using, you know, pretty tight, even if you're doing whole gland treatment, usually we use pretty tight boosting. There's really no consensus on dose. The dose I've most frequently been using is like 35 to 40 SBRT in 5 fractions. But yeah, the constraints that I mainly use is these 33, 36 gray. You know, I put this line in here is only use a constraint if you're going to actually use it, right? So if you have tumor abutting the urethra, like I think you just need to decide how much dose you want to give that. And if you think 33 gray is enough, that's fine, but sometimes it might need a little bit more. Next slide. I guess, yeah, the other comment I'll make is, yeah, the MR Linac, I think, is a really great tool. I think if we can, we try to get fiducials placed if they're not going to be on the MR Linac. Particularly like SD recurrences, I think are really helpful to do on the MR Linac, or like an adaptive. I think the ethos can do that. We're not currently doing that CT adaptive, but so this is what the plan looks like. You know, these were kind of cumulative doses. I did 35 gray and 5 fractions for him. Partial gland, just treating this kind of upper area. And these were kind of like cumulative doses. So hormone therapy. I think this is the big question, right? So next slide. I think, there's pros and cons. So I think on the pro side is if you were going to treat them initially with hormone therapy, like, if this is a Gleason 4+3 that came into your office, you would offer them hormone therapy. So why not offer it in reirradiation when you've proven it's more aggressive? In general, the higher risk prostate cancer benefits more from hormone therapy. The other potential benefit, could you shrink the tumor? Could you do some dose painting in that regards? I think if I'm going to do hormone therapy, I usually do like 6 to 12 months because, the point is to decrease their lifetime need for hormone therapy. So, right, like if you're going to do it, doing 2 years seems like overkill. The con argument being, exactly, the whole point is to avoid hormone therapy. So the whole point of doing the radiation is to reduce hormone therapy burden. If it's a local treatment, why are we doing a systemic therapy? Some of the reirradiation studies didn't really include hormone therapy. So if you're going to extrapolate from that, why are you breaching from the best evidence? And then the other trial I'll just put up here is the EMBARK trial, which showed, if you give guys with biochemically recurrent prostate cancer enzalutamide monotherapy, they have an 80% metastasis-free survival. And frankly, metastasis is the thing that we're all trying to avoid. They're not going to die of their prostate disease. So, if you can give guys an 80% chance of avoiding that with a single pill, that's a pretty high mark. So, these are the conversations. These, as Dr. Garant said, are long, lengthy consult visits. Yeah. So next slide. Yeah, so these are just some key points. Try to identify good candidates. Ideally, you have a long interval from prior radiation. Ideally, you have important imaging and biopsy. Ideally, they've had few side effects and tolerate the prior radiation well. They have a lower risk of distant mets. I get a little nervous anytime I see Gleason grade group 9 or 10. Choosing a technique. If you don't have HDR, I think, SBRT, MR-Linac are great options. Try and figure out some intrafaction monitoring. That gives you the ability to really reduce your margins and see what, kind of OAR swearing you can do. And then hormone therapy, I think it's still a little bit of black box. I think I frankly use my gut more and patience to guide than great data. I have a bonus case that was a Gleason 9 guy, but he was like a young, excellent performance status. So, eating my own words of like, would I? But, we started him on induction ADT. He had hydroureter. He had an excellent response. So I'm curious if the panelists would offer salvage radiation for this guy. Sorry, yeah, he had Gleason 9 disease. He had prior brachy and external beam, 18 months of ADT, but that was almost a decade ago. Now he has a recurrence PET and this MR showing this kind of superior lesion that seems to be originated where the LDR seeds weren't, and it kind of grew up into the bladder and the left ureter. So we started him on ADT. And then he had a great response, and I was kind of inclined to like, I don't know if I was just being a gunslinger, but curious if you guys would have just left him be.
Yeah, it's a really fascinating, pattern of relapse. These cases would definitely be reviewed at tumor board. Some of our urologists are in scenarios where we contemplate reirradiation with arguably, probably 45% repair if you account for time. They might suggest a prophylactic stent if they feel that the ureter is beginning to obstruct. And then we could proceed with careful reirradiation. And then that's kind of a dealer's choice at that point because we don't really know to what dose. We might get a response in very high grade disease, might get some abiraterone on board. Something of the sort.
It's a good idea with the stent. I think these are cases that I would definitely review with the MR-Linac team too, because I think this would be a good location for it. But it's so tricky post-brachy too. It makes me feel uncomfortable. These are so tough because you keep going back and forth, and you're not necessarily. It's hard because you never feel 100% about it, really, and then you're sort of crossing your fingers that they do okay after too, especially with that ureter and also bladder. So.
Yeah, so he got ADT with Abipret. He's still on it. He's a year out from MR-Linac re-irradiation, and PSA is still in the tactical, so we'll see. But he's on drug therapy.
Yeah, that was a fantastic case. One quick question. What about a case of a lymph node, just a single pelvic lymph? Do you go SBRT? I've seen kind of like a SBRT dose painting to the kind of like the lymph node area, or what is your preference?
Yeah, so we actually have like some data on this now. The PEACE trial looked at SBRT versus pelvic nodal radiation. And SBRT is good. My interpretation, I'm sure there's other interpretations. My interpretation is SBRT is good, but it does have a higher risk of like a regional relapse. I think about it like SRS versus whole brain, except the toxicity from pelvic nodal radiation is much, much lower. So our practice has typically been we very rarely do SBRT alone. We give them if they haven't had pelvic nodal radiation. If they've had pelvic nodal radiation, then we'll do SBRT. But we almost always do pelvic nodal elective RT with an SIB or to get involvement.
All right, out of interest of time, I'll let Dr. Grant take over.
Okay, I will zoom through my presentation today. So yeah, it's my pleasure to be here, everyone. I'm going to talk about renal cell carcinoma. Briefly, I have some disclosures, but they're not related to the talk. And as several of you may recall from studying for boards, RCC for the longest time was thought to be radio-resistant. And interestingly, my colleague Dr. Hanan wanted me to let everyone know that some of these older studies, if you dug into them very deeply, in terms of the RCC cell lines that were analyzed, they were actually done on a single young adult with a very rare subvariant of kidney cancer, which might not actually reflect the true radiosensitivity of RCC. And so I would say over the past 2 to 3 decades, there's been a lot of work done to, move past the dogma, and we can move on to the next slide. And essentially what we've learned over the past 2 to 3 decades is that it turns out that renal cell carcinoma is radiosensitive when exposed to correct dose per fraction. And so this was a study that was done on athymic nude mice at UTSW, and it showed that you could get excellent tumor control with high dose per fraction, 48:3 here. All right, next slide. And then following, animal studies, there have been some initially retrospective work done on SBRT in patients who were, quite comorbid and needing treatment for a growing primary kidney cancer. This was followed up by several phase 1 and phase 2 clinical trials. And I'd like to highlight a few of them before getting onto my clinical case. Next slide. This was an interesting one. From our colleagues over in Harvard, and essentially dose escalation study of SBRT for inoperable primary RCC. Interestingly, in this trial, they only had 2 local failures. If you look at all the dose levels that were studied and listed here, and both of those failures were in the low dose arms. So we've quickly moved past the low dose prescription for definitive intent primary SBRT. Next slide. Also, what's important to know for your personal practice is that RCC on conventional contrast-enhanced CT typically has enhancement with contrast, and following SABR or SBRT, there will not be any expected change in enhancement. What we expect to see is actually a range of effects on serial CT imaging, which is the most studied modality as of today. We're primarily going to notice a stunting of the growth. So for someone who's had interval scans over time, the first thing you'll notice as a measure of success from radiation is that the tumor stops to grow. Some patients will have partial response, typically in the 6 months and greater time frame, and only 2.4% of patients will actually experience a clinical complete response to SABR. And so when someone comes into your clinic and asks you, are you going to make my cancer vanish? you're going to tell them, well, about a 2.4% chance of that, but we still have excellent outcomes, even though it won't melt away or vanish. Okay, next slide. I think this is definitely a trial that you would anticipate to see on, clinical boards. This is a significant, successful study coming out from Australia and multinational study, actually, looking at feasibility of SABR either single fraction or 3 fraction 42 and 3 to primary RCC. On the trial, they allowed lesions up to 10 centimeter in diameter. But if you look carefully at the tables, the vast majority of patients had tumors that were 7 centimeters or smaller. And interestingly, at a median follow-up of 2 years, they had a local control of 100%, which is outstanding, and very low grades of grade 3 toxicity. Of note on that trial, they did notice a decline in GFR of 11 milliliters per minute, typically around the 12-month mark. Okay. This is actually our institutional experience, which was conducted around the same years as the Shankar-Siva trial. And essentially, we had slightly different fractionation, 36 and 3 rather than 42, as well as 40 and 5. And we had a local control of 94% with a slightly longer median follow-up. On the trial, interestingly, we also notice, if you look at that plot on the right-hand side, that a lot of tumors actually did not shrink or melt. They were mostly stable in size or shrinking ever so slightly. Next slide. On trial, we also mandated a 12-month pathology review, so patients were subjected to repeat biopsies for lesions that were still radiographically visible. And what we noticed is that there was a state of cellular senescence on the repeat biopsies of those lesions. So definitely signs that the radiation is highly effective when administered at high dose per fraction. Next slide. Something that's important to note, this is just a histology slide to show that the Ki-67 index is significantly reduced post curative doses of SABR for primary RCC. And if you look at the video here, if you'll just click on that image, most of you will know that kidneys tend to migrate primarily craniocaudally when with respiration. And so when you're simulating a patient for primary SABR or SBRT, it's strongly recommended to do at least a mini 4D scan, and depending on local resources, you can use either abdominal compression, deep inspiration breath hold, or active breathing coordination. IV contrast is also strongly recommended. And if you have access to MR-Linac with online imaging, that's also an added tool that could be helpful in your practice, although not mandatory. And so this is the case I'd like to present. This is Mr. G. He's 81 years old. He has a few comorbidities and an atrophic left kidney with known GFR of 54, which has been stable for the past 2 years. He's now presenting with a right-sided renal cell carcinoma, which was diagnosed radiographically during a hospital admission for a liver abscess. Next slide. I think I have a poll question. So what is this patient's CKD stage? Okay, I'll give everybody like 5 seconds because we have 5 minutes. Sorry to press. Right. Okay, I think most of you got the correct answer, so we'll move forward. It is actually stage 3. Okay.
Yep.
And next slide. And this is just to reflect that we have a GFR here of 54. Next slide. If you'll click play on the video, perfect. You'll see that there's a heterogeneously enhancing exophytic right upper pole renal mass. It's now measuring 8 centimeters. You can click play again. And so you can see it here. The radiologist kindly indexed the measurements of that upper pole lesion. And you can see a lot of kidney cysts bilaterally and an atrophic contralateral kidney. Okay, next slide. That's actually the MRI that the same patient underwent. Interestingly, the measurements are a little bit different. As you know, different modalities can lead to slightly different interpretation of lesion sizes. And based on the radiographic Likert scale of 5, this was considered to be a radiographic diagnosis for RCC. No other METs seen on clinical staging. All right, what is this patient's T stage? Okay, we'll take another 5 seconds. Right, and then answer on the next slide. Okay, let's see if you got it right. Excellent. And then presuming negative systemic staging, can this patient be diagnosed with RCC without a biopsy? I think I may have spoiled the answer. Okay, interesting. I get a mix of responses in the poll, so we'll go to the next slide. It turns out that it is actually acceptable to proceed with treatment based on high likelihood of clear cell or non-clear cell RCC. There are different scales available for your radiology colleagues to confirm the diagnosis. In the primary setting, I would say most of the diagnoses nowadays are radiographic with decision to either operate or ablate or irradiate. Although interestingly, radiation counts as an ablative technique under the NCCN guidelines. Sometimes on occasion, if you have locally advanced or metastatic disease, your medical oncology colleagues will naturally request a biopsy because it can help them guide management and obtain access to different types of targeted therapies and whatnot. But in the primary setting, a radiographic diagnosis is widely accepted, as you can see here on the guidelines. And so this is a case, Mr. G, he was treated with 4,200 centigrade and 3 fractions. This is the 2,400 centigrade isodose line, which you can see is actually quite conformal. And then I went back through the scan and looked at the prescription isodose line with a nice coverage of the PTB up to 95%. What I wanted to show here is that on the DVH graph, which is actually on the following slide, you'll notice that all of our DVH parameters are actually met, with the exception of the right hilum, and this is more of an expert opinion. I actually, did a poll through my disease-oriented team, and several of us, for lesions that are in the upper pole or near the hilum, we're not able to meet constraints on the hilum, and that hardly ever prevents us from proceeding with treatment. Given that we do consent patients for an anticipated decline in kidney function, especially over the first 1 to 2 years. Would any of the other experts on the panel, proceed any differently or reconsider their plan?
I wouldn't sacrifice coverage for that pilot constraint.
And so I wanted to show another case where you would imagine this similar patient. If you'll go to the next slide and run the video. It's a case where the anatomy was less favorable, and there was a loop of large bowel that was basically completely adjacent to the primary RCC. And so in this case, instead of 42 and 3, I decided to proceed with the 5 fraction regimen with decreased coverage to 90% of my initial intended PTV. And then the area that was overlapping with the bowel actually got a SIB dose, so that area got a dose fall off to 3,500 centigrade, in the PTV overlapping with the large bowel. So in cases of definitive management, on occasion you'll have to lose coverage, in order to prevent undue adverse events and toxicities. The stakes are certainly different in metastatic RCC, but that would be a topic that would take much more time to address and is still exploratory in many ways. So I think primary RCC is probably the most high yield in the present day. All right, thanks for your attention.
Thank you very much, Dr. Grant. One quick question about that case. So with Dr. Siva's kind of study where the max cutoff was kind of around 7 cms, if you have an even larger renal cell carcinoma, do you kind of fractionate it more, like the 40 and 5, or?
I personally go by OAR, meeting my OAR constraints. I think some of us have had exceptional scenarios of extremely enlarged RCCs invading the liver, tumor thrombosis into the IVC. Your rate limiting step in those cases is primarily duodenal dose. For the most part, at our center, we are big advocates for SABR or SBRT, so we'll mostly do dose fall off and reduce to 5 fractions. I don't remember the last time I've had to do more fractions than that.
Yeah.
Could do a whole webinar on extreme cases, but it is always extreme.
Yeah.
I'm seeing a quick question in the panel about NPO. I would say generally I ask patients to be NPO 4 hours for upper abdominal planning of any target. I have some anecdotes about in Texas, the understanding of NPO is pretty broad. 3 iced coffees counts as NPO here. So we do our best to ask patients to be NPO, but yeah, kind of take a look.
I think another thing to always think about too is like the small bowel is moving. We do hem and haw so much about these high dose metrics, and they're super important. And I think that, we try to find a balance between pushing it, but also like, having coverage of what we're focusing on. But, you see it a lot now that we have the MR-Linac and you kind of see the small bowel swishing around. So the reality is that same portion of the small bowel may not be getting all of that dose that you're kind of contouring in this sort of static setting when you're contouring on a CT scan or an MR scan. So
absolutely. Yeah.
Right. Well, yeah, I think all those cases were absolutely fantastic, and I thank you all for your clinical expertise on each of these cases.
All right. Excellent.
All right.
Thank you.
And we'll be
Thank you,
posting these on.
Louise.
Thank you.
All right. Take care, everyone.